Good afternoon, everybody. My name is Hannuy, Choi, and it's truly honored to be here as ZEISS APEC Partisan 2025. And I'm very honored to have this talk. And this talk is meant to be useful for surgeons who are about to start small surgery and who have a early experience in their small surgery. Hope you enjoy this talk. I don't have relevant financial disclosure, and we will be covering these topics, and I'm going to mainly focus on surgical tips and patient selection. Okay, let's begin. My clinic, BNB Eye Center, is one of the highest volume refractive center in Seoul, and we do almost 13 to 15,000 surgeries per year. Small is yellow colored, and as you can see, it has been growing since the introduction of the small surgery at our clinic. Back in 2012, when it first introduced, it accounted for only 1.6% of all the refractive procedures, but that shift has been dramatic. In 2020, more than 50% of our refractive surgeries were done with small surgery, and by 2023, that number surpassed 66%. I believe this trend reflects growing patient demand for minimally invasive options. Here is an interesting statistic I'd like to share, and this shows how much Korean loves small surgery and how much we have done small surgery so far in this very small country. Population-wise, Korea accounts for less than 1% of our global population, exactly 0.63% to be exact, and we've done more than 14% of the small cases globally. Well, knowing that interesting facts, let's move forward to more practical parts. Some basics of the small surgery. As anybody in this room would know, small is performed using a femtosecond laser, and there is 4 steps during the femtosecond laser. And it is important to know each steps and correlate each step to its surgical and anatomic plane. The first and the most critical cut is posterior lenticular plane, which determines the refractive outcome. Understanding the anatomy and the sequence of these cuts is essential, not only for accuracy, but also especially important when there was something unexpected had happened during the laser or surgery, such as when you encounter suction off during the laser treatment. I am not going to go over all the details about this, but you have to know this, and you have to know it well when you do the surgery. So let's move to the lenticule thickness and residual stroma thickness. By doing small femtosecond laser, you are creating 3 different layers of cornea: cap layer, lenticule, and residual cornea stroma layer. Cap thickness can vary depending on your setting, and usually it's around like 100 to 130. And for post-op cornea biomechanics, it's better if you can minimize cap thickness, but then a higher chance for incision site tear. And lenticule thickness is very much correlated to patient refractive error, the sum of myopic and cylinder amount. By knowing all these, you can calculate RSD, the residual stroma thickness, and maybe your technician or optometrist will do these calculations for you, but you still do need to know how RSD is being calculated. And this table can give you the sense of lenticule thickness. Let's say we are going to treat -4 diopter myopic patients. Then it means that the lenticule thickness is around 80 microns, and it's going to be same lenticule thickness with the patient with -2 diopter myopia and -2 diopter cylinder, or patient who has only -4 diopter cylinder. So it's pretty straightforward that lenticle thickness is going to be the same if the sum of myopic amount and cylinder amount are the same. Also, lenticle thickness depends on the optical zone. The larger optical zone you make, the lenticle thickness will become thicker. Let's have a look for 100 microns of lenticle thickness. In 6.0 millimeter optical zone, 100 micron accounts for -7 diopter correction. But in 6.5 optical zone, 100 micron can be treated only 5.5 diopter. So by adjusting optical zone, you can adjust lenticle thickness a little bit. If it's easier, in 6.0 optical zone, it takes 11 microns to treat 1 diopter, and in 6.3 optical zone, it takes 12 microns to treat 1 diopter. And in 6.5 optical zone, it takes 13 microns to treat every 1 diopter. And I'd like to share some of the surgical tips that I wished I had known when I started small surgery. And some of them are just very, very basics, but I still like to go over some of the basics too. So when I started small surgery, my mentor, he said, the most important thing when you're doing the small surgery is that delivering laser to cornea well, from start to end. So for SMILE, it's probably around 20 to 25 seconds, and for SMILE Pro, it's going to be around 10 to 12 seconds. To make this happen, nice and good delivery of the laser to cornea, you want to do 2 things. One is that your patient needs to stay still the whole laser time, and surgical site needs to be clean, meaning cornea should be clean, and there should be no foreign body on tip of the SMILE cone. It's very, very basic for not only small surgery, but also for all other ophthalmology surgeries. You want your patient's head and body posture to be in the right position. If patients are too nervous, some would lift their chin and some would pull down their chin, and this will make small site discentered. If your neck is in a flexion position, then it will cause inferior decentration, and if your neck is extended position, then it will cause superior decentration. So you don't want that. And also try to see if the body position is well aligned with the head. It wouldn't take that long, just check overall patient's position. And these will be reviewed going forward. And to perform a beautiful, clean lenticle dissection, you have to know the importance of the counterforce, which means that you want to fixate the eyeball during your dissection. And any instrument that can fixate the eyeball will do the job. It can be forceps, it can be Q-tip, and I personally use my dry aerosol to fixate the eye. Also, if you completely dissected certain part of the lenticle, both anterior and posterior, then lenticle it's going to start to roll. So if this happens, it will be a lot harder to proceed the dissection. So for beginning surgeons, I would recommend this, that you leave some parts. I call this supporting tissue parts, here marked in the red color, and undissected so that they can hang on both sides, preventing lenticle from rolling. And at the most end of the lenticle dissection, you just slightly touch with your spatula, and lenticle will become completely off. Okay, moving to the next one. How to engage in anterior and posterior plane easily. Before I start my first small surgery, this worried me a lot. What if I can't really find the right plane, or what if I can't find the upper plane or lower plane? I think for most surgeons in their very early experience or before starting their less than like 5 or 10 cases, maybe they would have same worries as me. And the tip is that you are guiding yourself to the right plane. To do so, you split the path for upper level path and lower level path. So to get your spatula to the upper level of the lenticule, you guide your path to left side of incision. So here, you guide yourself path to the left side. So this is incision. You guide yourself to the left side of the incision area. And here in this picture, it's this purple color. And you slightly tilt up the instrument to make sure that your upper level path or just pouch on the left side. So what I'm trying to say is that if you make the upper level path on the left, then that will guide you to the upper level if you put the instrument in that direction. And to make the path for the lower level, the inferior plane, then this blue color, you slightly make downward movement, and the key is to make that path on the right side of the incision. So if you make that incision construction well, then if you engage your spatula in a purple direction, then it will naturally go over to lenticule. And if you engage your spatula with a blue color direction, then it will naturally take you below the lenticule. Okay, next topic is incision. And one of the most common mistakes that novice surgeon would be encounter is that you will tear your incision laterally, either right side, left side, but laterally. And this is also very important to have the concept of pivot movement. Imagine you are making CCC when you're doing cataract surgery, and you use this pivot movement, and it's almost the same. And you have to use pivot point at the site of incision, like here, when you dissect the lenticule. But in early small surgery, it's highly likely that you will use your wrist as your pivot point, which is shown here. And the incision site, if this happens, there's a high chance the incision site will tear, and you will have that experience. So make sure you use incision site as a pivot point. I was just talking about X and Y axis movement at the previous slide, and now I'd like to emphasize on Z axis movement. You really don't want to make Z axis movement. That will definitely cause incision to be teared off, and this can usually happen after a complete lenticular dissection, and when you try to pull lenticule out from the cornea. Let's say this orange color is a dissected lenticule waiting to be pulled out, and if this lenticule is located very across from the incision site, you try to grab it, but sometimes it's not well grabbed. Sometimes it happens. And then you start making this downward movement with the instrument, the angle, to better grab this lenticule, and that will make this Z-axis movement at the incision site, and then incision can be teared off. So instead of trying to grab it from from there, you might want to move that lenticule to the side, either here or there, and grab your lenticule from the other location where you can access more easily. Other than what I've gone over, there are many situations that you might encounter as your small number gets accumulated, and try to think about how you're going to manage if these situation ever happens during the future small surgery. And knowing how to deal with it and you encounter unpleasant situations much more better than you encounter these situations without knowing what to do. And so I'm gonna go to, okay, you might want to start your small surgery with bigger incision and probably 2.3, even 3.0 millimeter, and gradually shorten to 2 millimeter if you become more comfortable with the surgery. And for cap thickness, you can start with thicker cap, like the cap thickness like 130, and gradually make thinner cap thickness to 115 or even 100. I like to use my incision as 2 millimeter and cap thickness of 150. Okay, the last part of my talk is going to be patient selection for initial small surgeons. This is my concept of plano. I think actually this is really important slide. So plano is not the situation with no refractive error, in my opinion, but refractive state that can be achieved 20/20 vision uncorrected. When you were younger, even though you have like +1 diopter hypro, or even with slight myopic, like half diopter myopic, you can still see 20/20 uncorrected. But this range will become narrower as you age. And the range of 20/20 vision will narrow down to actual dictionary plano, meaning no refractive error, to be able to see 20/20 in your late 30s. So when you select your first few patients, I recommend you choose a patient with wider range of 20/20 vision, the patient who can still see 20/20 vision even with a little remaining refractive error. So try to start with early to mid-20s and slightly make wider range of patients. And also, if you operate on very low myopia, then the lenticule is going to be really thin and the patient will not tell too much difference pre and post-op. So it's not probably the best idea. And also I don't recommend too high myopia for your first few cases, because if something ever happens, hopefully not, but if happens, it's really hard to enhance or treat if there's not much remaining cornea thickness. Also, astigmatism, you want to start small with low cell patient and see how the results are, and widen your range of astigmatism as well. And lastly, patient cooperation. This is something I've done in my first year of my surgery to all of my patients before you enter OR. When you examine your patient in a sling mount, I always asked patient to look down, and I would lift their eyelid upward, and then you will have this feeling that this patient will do great during the surgery, or the surgery is going to be really hard for a patient and me as well. So if you have that second feeling, then this patient will show very bad cooperation during the surgery. So take a couple more minutes to really explain what will happen during the surgery and educate the patient to open both the barriers throughout the surgery and try to relieve some of their anxiety to have better patient cooperation during the surgery. So that's all my talk, and this is the summary of the talk. Thank you for listening.
Okay, thank you for the talk. Are there any questions? The floor? Okay. I have a question. What is the main cause for, Korean people is very small, but portion of surgery is very huge? What's the reason for that?
Pardon me? Could you repeat that question? Could you repeat the question?
Okay. Portion of Korean population is very small, but portion of surgery is very huge. What's the reason for that?
This is very unfortunate for Korean ophthalmologists that the price point of Korean refractive surgery is pretty low. I think that's one of that can explain one reason.
Mm-hmm.
And people don't like to wear glasses in Korea. Since the the surgery, it gets more popular. My friend got LASIK or SMILE, and my other friends got surgery, then it makes patient feel that having that surgery is not a real big deal. So that is a threshold of getting surgery to really. For some country, they have to make a lot of effort or decision to get this surgery done. But in Korea, too many people get this surgery, and even parents will hold their child's hand and come to clinic to get their children's eyesight. So I think that explains it.
I think also surgery is a play role to room of the smile surgery. Okay. Thank you.
Good afternoon, everyone. I would like to thank Carl Zeiss for involving me in this training session on SMILE. And today I'll be talking about the learning curve of SMILE and would also give you some tips about how you can make the learning curve of SMILE easy if you're a beginner. So why SMILE is considered more challenging than LASIK is because here in this procedure you need to remove a refractive lenticule through a small incision, and that is something that that needs a bit of surgical skill, and you can have challenges during this step. However, now with the introduction of the Visumax 800, which is the more advanced version of the 500 machine, I feel that the learning curve of SMILE would be easier for beginner surgeons because of its more advanced features. Its faster scanning and high repetition rate of 2 MHz, which brings down the lenticle creation time to under 9 seconds. Its swiveling arms and laser for laser and operating. The device docking is by the device movement, unlike the bend movement in Visumax 500. It also has central and ocular assistance functions for better control of cyclotorsion and centration, and as well as the digital connectivity and refractive workplace. So the previous speaker has already discussed about the indications and contraindications of SMILE, so I will not repeat these. However, this is the approved range of refractive error that can be treated. So a sphere of up to -10 diopters, cylinder of up to 5, spherical equivalent of up to -12.5. A patient should have a stable refraction in the past 12 months, which is changed less than 0.5 diopters in the past 1 year, suitable topography, and ensure a good residual wet thickness of more than 300 microns, a healthy ocular surface, no ocular inflammation or infection, rule out keratoconus or any kind of ectatic disease of the cornea or scars, posterior segment should be normal, and contraindications would be pregnancy and immunosuppression. Now, this is the geometry of the SMILE lenticule. You have the lenticule cut, which is the other side of the lenticule, then lenticule side cut, cap and the cap opening or the incision. So all these parameters are customizable depending upon the case, the parameters. You can customize these settings. Now, about the energy settings, of course you have to have an optimized energy setting. Visumax 800 is a high frequency, low energy femtosecond laser. So as a beginner, you may want to use a slightly higher energy cut index, because when you use a little higher energy, it helps helps to separate the lenticule easily. So as a beginner, you can use an energy cut index of 27 to 28 that corresponds to energy of 135 to 140 nanojoules, and the spot separation of 4.5 microns for the cap and 4.3 microns for the cap, and 4.5 microns for the cap and 4.3 for the lenticule. So this is also something that can help you with the better dissection of the lenticule and easy dissection of the lenticule. So, and as you gain more experience, you can reduce your energy cut index and bring the spots closer. So that can be done for, that helps with the first day visual recovery. So tips for eye preparation and prevention of black spots, that's very important because in smile, you have to take care of the surface. So if the cornea has to be just moist. If the cornea is too wet, it can lead to suction loss. If it's too dry, it can lead to black spots. If the lids of the patient are very floppy, you can use a solid grade speculum. It's better not to use too much of topical anesthesia because anesthesia can dry up the cornea and also make the surface of the epithelium irregular. So this is how I like to prepare the eye. So once the speculum is put, I use a moist sponge to just clean the surface of the cornea before going ahead with the docking. And if there are too many meibomian secretions, then it's also better to rinse the surface of the cornea. So this is a case of black spots. So generally these black spots you can see because of the overuse of the topical anesthesia, repeated touching of the contact glass, any foreign bodies like dirt or fibers coming under the contact glass at the time of laser delivery. So this is a case where you can see that there are black spots in the center and as well as near the incision. So the challenge you can face in these cases is difficulty in finding the planes as well as dissection of the lenticule itself. So I am able to dissect the anterior plane, but you can see that the entry into the posterior plane is challenging. So I go back and go a little deeper, and now I am able to find the deeper plane and enter. And this case had some black spots in the center, so in these areas you will have to do a firm dissection. So if the black spots are small and they are scattered, you can go ahead with the dissection. But if there is a big black patch anywhere, whether in the center or in the periphery, it may not be a good idea to go ahead with the dissection, and you may want to abandon the case. So if you see too many black spots, it may be a good idea to rinse the surface of the cornea with copious BSS and then go ahead with the laser ablation, and you can see you have a good bubble pattern. So about successful docking and suction stability, I would like to give 10 tips. So the first tip is ensure that appropriate suction is achieved. So make sure there is no gap between the contact glass and the cornea. Avoid tight speculums and drapes blocking the nose. So if the patient is uncomfortable, the speculum is too tight and the drape is blocking the nose, patient is not able to breathe properly. So because he is uncomfortable, so they will not cooperate during the docking. If the patient has deep set eyes, very high eyebrows and big nose, so if the facial anatomy is such, it may be a good idea to tilt the head to the other side and make some space, and so the contact glass does not touch the nose. Also watch for the area around the contact glass. It should be dry and there should not be too much fluid. So if there is too much fluid, you need to soak this fluid and then go ahead with the docking. To improve the fixation to the green light, you can tape the other eye. That helps the patient to fixate on the green light better. The dock should be gentle. It should not be a very hard dock. Make sure there is no conjunctival prolapse. So if the patient is a contact lens wearer, sometimes the conjunctiva prolapses. in the cone, so that also predisposes to suction loss. The environment in the OR should be calm and quiet, so make sure that your staff or anyone is not talking, there is no music or some sounds which are distracting the patient. And make sure you maintain a good communication with the patient and inform them about the green light. And now with the 800, it just takes about 8 to 9 seconds, so it's good to give a countdown also. And last but not the least, giving the patient a pre-medication for anxiety. So I like to give 125 mg of alprazolam 20 minutes before the procedure. Also helps to calm down the anxiety before the surgery. So this is a video of docking with Visumax 800. So here you can see that so I've switched on the infrared, and this is the central line function being used. So you have this vector, you need to bring this vector in the circle, and when you see this blue, the dot is blue, it shows that the centration is within 100 microns. And once it is well centered, you can go ahead with the laser ablation. So centration in the Visumax 800 is based on the central line, and this is based on the X and Y coordinates of either the IOL Master 700 or the topography. So if you're using the coordinates from IOL Master 700, you can use them as it is. But if you're using the coordinates from topography, then you need to change the signs, and then you can go ahead with the centration. So this is the few videos of suction loss. So I think subsequent speakers are going to talk about the complications. So make sure when you are docking the eye, there is no conjunctival prolapse. So this is a case where the eye was docked. This is a case with Visumax 500. And when the lenticle cut was being done, there was a suction loss, and this was more than 10%. So whenever there is a more than 10% progress of the lenticle cut, you need to abandon the SMILE procedure. And if you want to finish the procedure in the same sitting, you will have to convert it into femtosecond LASIK procedure. So this is basically how you can manage suction loss. Follow the commands on the screen. Look for the completeness of each stage. So each stage, that is the lenticle cut, side cut, cap cut and incision cut, is divided from 0 to 100%. And you need to see where the laser stopped when you had suction loss, at what stage. Based on that, it's going to guide you. So the general dictum is to convert to femtosecond laser, femtosecond LASIK, if the lenticle cut was more than 10%. For all the other stages, that is the beginning, which is less than 10% of the lenticle cut, side cut, cap cut, as well as the incision cut, you can continue with SMILE. So some tips for the successful surgery. So it's important to find the plane, proper plane identification, proper surgical dissection, as well as instrumentation. So for proper plane dissection, there are two signs that are described, the ring or the double X sign and the stop sign, which can be used. So this is the surgical technique that I use for dissection of the lenticle. So always I like to fixate the eye, and before using the forceps to hold the eye, I like to put topical anesthesia at 4 o'clock or 5 o'clock position. This is where I am going to hold the eye with the forceps, so the patient is not very uncomfortable. It's also a good idea to massage the center of the cornea. Next step is finding the planes. So with the sharp side, you find the anterior plane on the left side and posterior plane on the right side. Then I like to ask the patient to look down. So when you ask the patient to look down, it makes it easy to enter into the superficial plane. So make sure you go back in the superficial plane and not in the deeper plane. For the dissection of the anterior plane, you need to dissect it completely, going towards the sides, and do a 360-degree movement to ensure that the sides are also cut well. For the deeper plane dissection, I like to dissect mainly the central part first, then go to 6 o'clock, and then 3 and 9 o'clock position. And then I like to keep 2 small undissected hinges at 3 and 9 o'clock position to give counter traction. And then finally cut these hinges one by one. You can either use a forceps to remove the lenticle, or you can go above the lenticle and remove it using the same instrument. Washing of the interface is optional. If you feel that you have gone in the interface too many times and there may be a chance that you may have implanted epithelium inside the interface, then it may be a good idea to wash it. Otherwise, if it was a single step removal of the lenticle, you don't have to wash the interface. So this is a video showing posterior plane entry and lenticle getting stuck under the cap. This is the case being done by a trainee. So he has found the planes correctly, but while entering into the superficial plane, you can see he has entered the deeper plane now. So the signs that the dissector is under the lenticle is, you will see a lot of bubbles over the dissector. So then I have taken over the case and I have gone from the side and found the superficial plane. So you need to insert the sharp side of the dissector between the cap and the lenticle. So then you do the same steps in the superficial plane. Now the deeper plane is already dissected. So keep the 2 hinges on the sides and carefully the lenticle was removed. Cap or incision here. This is again a trainee case. So you can see already the incision is 4 mm for a trainee. And when he is trying to remove the lenticle, you can see that the cap or the incision is getting torn on the right side. So it's better to ask the patient to look down, because this creates more space, and it's also important not to lift the incision, because if you lift the forceps, then the incision has chances of extension. So this is how the lenticle was removed. Instrumentation again is very important. So you have the Chansu dissector, advanced Chansu dissector and Weinstein dissector. I personally like to use the advanced Chansu dissector, and this is what I like to give my trainees, because this is much better in finding the planes. With the Weinstein dissector, it has a tendency to go in the deeper plane first. So I find in my hands the advanced Chansu dissector working best for me as well as the trainees, because it's broader, it's circular, it has a flatter edge, it's useful to identify the superficial plane. And also if you have black spots, it's good for cutting on the black spots because it has cutting edges. So tips for astigmatism eyes. So SMILE was shown to undercut with the rule astigmatism. So if you have with the rule astigmatism, it's better to use a nomogram. So I like to use a 10% nomogram for with the rule astigmatism. For oblique astigmatism, 5%, and for against the rule astigmatism, don't like to use any nomogram. For Visumax 500 users, for astigmatism more than 1 diopter, corneal marking at 0, 180 degrees and manual rotation of contact glass can be done for cyclopausion adjustment. But for 800 users, this is automatic using the oculine feature. So oculine basically, it's enabled due to the digital connectivity of the IOL Master 700, the refractive workplace and the Visumax 800. So the iris registration data is captured with the IOL Master 700, and then this is transferred to the refractive workplace and finally to the Visumax 800. So on table, this is how you see. This is how the compensation of cyclotorsion is done. So this is a case of high cylinder where 3 degrees cyclotorsion was there, and you see this overlay, this which appears. So you can check the live image with the iris image of the IOL master, match them, adjust the cyclotorsion, and then go ahead with the laser ablation. So this is how it automatically corrects for the cyclotortion. So you can have situations where you may not be able to remove the lenticle, so this is called failed smile. So inability to remove lenticle after repeated attempts. It's better to abandon the case and review the case after a week or so. Assess the patient with visual acuity, refraction, topography and OCT. And if it's a case of a retained lenticle, then you have different options such as circle software, re-intervention through cold smile incision or topography guided treatment based on the condition of the eye and the situation of the lenticle in the pocket. So take home points with appropriate knowledge, training and skill enhancement, the learning curve of smile, which was once thought to be challenging, can become smooth and less overwhelming for a beginner surgeon. And now with the Visumax 800, its faster speed, centration and cyclotorsion assistant functions, and the digital connectivity with the refractive workplace, it allows for better control and helps develop confidence from the very early stage of the learning curve of smile. So these are some tips and tricks for successful smile as beginners. So thank you so much for your kind attention. If there are any questions, I will be happy to answer.
Thank you. Thank you for your report. Are there any questions? So you mean that successful docking and suction cell is the key to the successful surgery. So you mentioned that deep-seated line and high eyebrow is a tricky thing to successful docking. Can you explain about your idea for that?
Yeah, so some patients have very prominent brows and very prominent nose. So the eyes are deep set. So in these cases, docking is challenging. So you have to make sure there is not too much fluid around the cone. So make sure that you soak the excess fluid before docking. And you need to make space for the contact glass to touch the eye. So it's better to ask the patient to basically shift the position of the head to the other side. So that brings the eye and the cornea in the center and creates space for the contact glass. So that's something that can be useful.
And your suction nose case, over 10% proceed or post-identical. Your choice is to convert the epiphylacy after 3 months. In Korea, according to the SMILE forum, we try to reduce immediately, and then guidelines are different, but we try to reduce the suction and then try again.
So you try to redock,
Yeah.
And then
Immediately.
Yeah, yes.
After the suction nose. So.
Yeah, so you proceed with femtolastic?
Smile surgery.
Smile surgery. Okay, so then you cannot use the same patient interface and license. So you plan a new treatment then.
Any idea for that? So
My preferred choice, because with smile, even though with 800 there is always a risk of suction loss, even though the suction time is less. So we always explain that there can be chances of suction losses, and your procedure might have to be converted into femtolastic. So this is a possibility which is always explained, and if the patient is fine, then I would like to go ahead with femtolastic at the same time.
Okay. And over 10 years ago, when I was beginner for my surgery, if something wrong, and I'm doing some lenticle cut, I just stop. Just stop. Later, here I came or other option. But now, just another. Okay. Thank you.
Thank you.
Good morning to everyone. I'm from Taiwan, and my topic is smile. Every step matters. And honestly, I don't think I performed as much as smile surgery as other three pretty speakers, but I think I'm here, right? So I'm going to share some steps that I think are really important before the laser firing. The surgery begins the moment the patient enters the operating room. In our practice, the first thing we do is examine the patient. Examine the patient under the slit lamp, making them feel confident and ready. And I will briefly go them through the entire procedures. But before anything else, the first question I ask is, are you nervous? There are three types of answer that I usually hear, which help me classify my patient and determine how much guidance they may need. If the answer is, oh, I'm very, very nervous, or not at all, it's a red flag. Because mostly, if the patient say they are no feeling, they may hiding or suppressing their anxiety, so they will be out of control at any time. And when examining the procedure, I usually tell my patient there are three parts of the procedure. And this helped me manage when they might feel nervous and I need to, and when they should stay relaxed as I need to concentrate at the same time. And let me try to explain it as I try to explain to my patient in English. Okay, hi Jason. How are you? Are you nervous? Oh, no worry. It's a really easy procedure. The smile can be divided into three parts. During the entire whole procedures, you only need to do one thing. Look at the line with your both sides. If you feel nervous, look at the line with your both sides. If you feel a little discomfort, look at the line with your both sides. It's a very easy language that they know that what should they do during the discomfort. And then continue the explanation. And in the first step, I'll have you practice looking at the line, and in the meantime, I will check the correction. I reflex, and in the second step, we will prepare to fire the laser. In the third step, the hard part is over. You can relax while I gently remove the lenticle. The voice in my heart is that I may be nervous at the time. Please don't bother me. And here I illustrate the pressure levels of both the patient and the beginner surgeon. Many beginners, as I did, start to be anxious after the laser firing. And patients usually feel a bit of stress at the beginning, and the stress increases when they have to face the green light or the laser. One side is down and the other. I hope they can feel relaxed when I'm removing the lenticle. And how do you guys think the stress curve looks like? From the famous novel, The Little Prince, it's not a picture of a head. It was a picture of a boa constrictor digesting an elephant from a famous novel, just like this. So I think the key to smile surgery is not just the laser firing or lenticular extraction. It's the steps before the laser that really matter to a beginner, because you don't want the elephant to get bigger like this. And never forget that the landmark study concluded the reflection of coaxial light, or we call the Purkinje image. Although the closest, very close, but it's not the same as the visual axis. Because the visual axis is defined as the line joining the fixation point and the fovea by the two nodal points, because eye is a thick lens system. It is close to, but not the same as the line of sight. So we perform what we call triple centration. We use at least 2 tomographic scans and the Purkinje image to determine the angle kappa. Gray spots are another issue that we can take steps to prevent. Previous studies have suggested that controlling the thin film with irrigation may help improve reflective outcome and integral extraction. However, extra irrigation may bring out more oil from the fornix, so we come up with another solution. Our idea comes from a small observation. After releasing the suction during smile, a tiny droplet of water often remains on the contact glass. That inspired we call the Formosa dew method. We simply use a aerosol sponge to place a droplet of water at the center of the contact glass after docking the interface. It's quick and easy, so easy that I did it during my very first smile surgery. Okay, let's see it again. After docking the patient interface, we use our left hand to place the water drop and our right hand to keep controlling the joystick. And it seems easy, but there's real physics behind this. In SMILE, 2 surfaces meet, the hydrophilic NBK7 optical contact glass and the corneal surface, which is coated by a tear film made of an oil layer on top of a muco-aqueous layer. When the droplet is applied, its pressure helps to expel the oil layer, creating a more stable and a cleaner contact. Hydrogen bonding between water molecule helps maintain that connection. Without the droplet, the oil isn't expelled, it just spreads. And we think there are 2 key principles to this technique. First, after applying the droplet, we gently brush the corneal surface to minimize the residual oil. Second, the soft docking technique was recommended to avoid turbulence, which could emulsify the oil and the water layers. Soft docking means only about 70 to 80% contact before turning on the suction. Formosa is a Portuguese word meaning beautiful. It's what the Portuguese called Taiwan when they first met the island. And water resources are also very precious to Taiwan. We call this technique Formosa dew method. With just a single drop of water, we can achieve a beautiful cut. We recruited 25 patients with 50 eyes in each group. All surgery was performed by a single experienced surgeon, my mentor, Dr. Chong Zhang, using the same nomogram. Baseline characteristics like refractive error, CCT, and high order relation were similar between groups. We found no significant difference in suction attempts or suction loss between the groups. Interestingly, the group without the droplet had a higher rate of tiny black spots, defined as at least 3 spots within the pupil margin at 56.25%. This technique showed its promise as a useful addition to our routine practice. Post-op high order relation did not differ significantly between the 2 groups. And lastly, central line is a great design to give a sky to angle kappa. When we see the shining yellow light, it means we are at 0.2 millimeter. When the light turns blue, it means we are at about 0.1 millimeter. There are some keys that I think are important. Try to avoid covering the entire face, just like we did in cataract or retina surgery, the entire face with your sterile drapes. We use open drapes so we can see if the patient tilts their head or moves their head. And when you using the central line technology, you feel you are tracing the yellow balloon like a donkey chasing the carrot. You try to reach it, but after little adjustments, then you cannot still get the point. There may be large angle kappa, or actually the patient didn't look at the green light. So just release the contact. So just release the contact and remind the patient again. Sometimes if the angle kappa is large, we can just get the closer point. We can get, then most of the time the suction will drag the cornea surface to its right position. Okay, if you are a beginner in smile surgery, try not to make the elephant bigger at first. Then as you practice, I think everyone can digest that elephant. And as I do now, let's smile and feel great throughout each case. Thank you for listening.
Thank you. Any questions? I want. Actually, I used to use artificial tears for the docking, and your promotion technique is a little similar. So, did you have any change the parameter or number?
You mean the chamber or?
Change the parameter or number of patient.
And due to the the droplet.
Yeah, how much do you think?
Because actually I didn't mention that the rate of OBL is kind of higher, a little bit higher than the group who didn't use the technique. So I think I suppose that the energy transmission is better after like irrigation or like we use the droplet of water. And maybe but recently because we regularly use the droplets in each case, so we use the same nomogram, same energy setting. Yes. Thank you.
Good afternoon, everyone. Thank you for having me here today. I'd like to thank Zeiss, and it's an honor to be here and speaking about the complications in SMILE. I've kept my talk short today, and I just want to present 3 cases and discuss the complications case-wise. So here we go. I'm a consultant for Carl Zeiss Meditech. So this is the first case. We've already spoken a lot about how much fluid to use while docking and black spots, but also one really important thing to keep in mind is the conjunctiva and how sometimes it can come into the ports. So let's have a look at this case. You can see here that the docking is happening normally, and here we've put the IR on. It's a little bit difficult. This is the second time the docking has taken place. And as we dock, we put the infrared light on. So once we put the infrared light on, you can't really see the details of the limbus too well. So here, after the infrared light goes off, the surgeon has noticed that there is conjunctiva in the ports. But you cannot stop the laser once you've started it. So what has been done here is a diamond blade is used to make the incision, because the conjunctiva has come in the way, the laser has fired over the conjunctiva, so the incision has not been made. So a diamond blade is used to actually create the incision at the right plane, and then the dissection can go on normally. Now here, in such cases, what can also happen is that the incision can be partially made. So you can even use the partial incision to continue with the dissection if the incision is not fully complete. But in case the incision is not made at all, this is one of the solutions. This is an innovative solution. This is one of Dr. Sriganesh's cases. So this was an innovative way to deal with this tricky situation where the incision was not made. This is another case. We are now talking about lost lenticules, right? Once you dissect the lenticule, but a part of it is left behind in the interface. So this is a case where a procedure called lenticuloschisis is being attempted. So lenticuloschisis is a technique where the forceps is used to dissect the lenticule without the spatula. There is no dissection done by the spatula, and usually it happens very smoothly. It is reserved for more advanced surgeons. And here you can see that there is a little bit of OBL, and the pattern is not very homogeneous. So at the end you can see there's a small sliver of lenticule left behind there. So the surgeon is actually opening up the lenticule, and you can see that there's a small sliver in the periphery there that is missing. So here, the best thing to do is go back and dissect it. Here, just the microforceps is being used to grasp the edge of the lenticule and peel it off from the periphery. And that small little piece fits into the rest of the lenticule like a jigsaw puzzle. So this actually tells us how important it is to always unfurl the lenticule and have a look before we finish the case, right? What you can also do is use a rescue instrument. We sometimes use the Chancery dissector to dissect the superficial and deep plane of the retained lenticule to loosen it up before actually removing it with a microforceps. So that can also be done. Now this is another interesting case of a retained lenticule. So this is a little bit of the case history. It was a 33-year-old female having undergone SMILE in both eyes. The left eye had a history of a complicated surgery, and when this patient came to our center, the best corrected distance vision was only improving to 20 by 40 parts. And this was the refraction, -1 sphere with -1 cylinder after the SMILE surgery. So let's see what happened. We were able to get the original primary surgery video. You can see a large black patch here, and the surgeon has decided to go ahead with the case in spite of the large black patch. So you see here that the dissection is fairly normal. The deeper plane near that dark black patch is a little more difficult than usual. But the lenticule comes out in toto, it's complete. You can see all the edges are complete and the lenticule is complete. So the surgeon is happy and thinks that it's an uneventful case because the whole lenticule has come out. But look at the topography. You see the left eye topography? There is this bump in the middle, which clearly there is some retained tissue there. Now in this case, an ASOCT was done, but there was no clear indication of any tissue which is left behind in the interface. You can see that it's smooth, you can even see the interface. There's no obvious bump of tissue that's left behind, but on the topography it's seen. So what do you do at this stage? Now it's really important to dilate the eyes and do a retroilluminated slit lamp examination. So on retroillumination, can you see this? You see this edge right here, right? You see the edge here. So that's where the retained tissue is there. However, you cannot explore the same SMILE pocket. Whenever you have any retained lenticule, you have two options. You can either go through the same incision and explore the same pocket, or you can convert the cap into a flap and do an open exploration. Now, when you can see an obvious lenticule on ASOCT, you can pinpoint exactly where it is, visualize it before the surgery. That's when you can use the same pocket, go in and explore the same SMILE pocket. But when the sliver of tissue is so small and thin, and the whole lenticule looks like it's come out in toto, then you don't know where you're looking, right? On the slit lamp retroilluminated picture, you have an idea that it's somewhere there in the superior temporal area, but it is a little risky to go through the same incision. So what we do is we use a circle software. So this is an off-label use for the circle software where it's able to convert the cap into a flap. So let's see how that's done. So this is the circle software. It extends the cap and converts the cap into a flap with a nasal hinge. So you see the flap is lifted, and the Siebel's flap lifter itself is used to remove that sliver of tissue. You just pick at it at the sides carefully, very carefully. You can see how rough this interface is. This is because of the black spot. So the dissection has happened within a layer of the lenticule, and a part of it is left behind. So the small circular tissue that you can see was the bump that we saw on topography. And then a 20 micron PTK is done as a smoothing procedure to make the interface smooth. So this was how this patient was treated, and you can see the results. The pre-op topography versus the post-op topography, that bump is completely gone. And you can see on the retroilluminated picture also that comparatively that shadow which was there in the superior temporal area, that has also disappeared. That's because that little sliver of tissue. So be very careful of black spots, especially when you have a large black patch like this. It's better to abandon the case and do maybe a thin flap LASIK above this cap cut to ensure a good result, rather than go ahead with the dissection and have complications like this, which can be quite tricky to treat. However, this patient ended up with a good vision, uncorrected vision of 20/20 parts, and eventually within 6 months it was 20/20. So this was how this patient was managed. You can also see the difference between the OSI, pre-op and post-op. Now this is a parameter of the HD analyzer. You can see pre-operatively the OSI was 9.2, and this gives you a simulated image as well. So you can see the patient is hardly able to see anything. After an uneventful smile, they should be able to see well, but the OSI is 9.2 and hardly able to see anything, versus post-operatively the OSI is still a little high on post-op day 1, that's 2.5. But patient is comparatively able to see much better on day 1, and eventually in 6 months it cleared up and came below 1.5. So this is again the last case that I want to discuss today, the mystery of an uneventful smile. So this case again came to us as an uneventful smile surgery. It was a 45-year-old male patient, so note the age as well, right? The 45-year-old male patient who underwent smile and uncomplicated smile procedure bilaterally about 6 weeks ago, complaining of blurred vision in both eyes, which was not improving with glasses. So both eyes underwent uncomplicated smile. Patient was not able to see anything even after 6 weeks after the surgery. This was what the pre-op refraction was. It was a low myopia, minus 2.5 diopters in the right eye, minus 1.5 sphere in the left eye, with about minus 1 cylinder, and patient was seeing 6/6 pre-op with the correction. Post-operatively, you see again the refraction has completely changed. The right eye has developed a minus 1 cylinder, and the patient is not improving beyond 6/9. And in the left eye, the patient has developed like a mixed astigmatism kind of picture with a 1.5 sphere and a minus 2.25 cylinder, and the patient is only able to see 6/18, so the vision was really bad in the left eye. So this patient was referred for opinion and management. So let's look at the first surgery. So you see here the laser pattern looks fairly homogeneous, no black spots, no obvious OBL, but the pattern does look a little brighter than usual, but fairly normal looking surgery. You see the pattern is good. Okay, and this was the dissection. The surgeon has used a Chancery dissector, but fairly normal, and even if the dissection was a little traumatic, you can see that the lenticule is completely removed. So this was what the topography looked like, fairly normal, right? Post smile, it looks a little bit of against the rule astigmatism, but other than that, the pattern looks fairly okay. No obvious bump there, like a retained lenticule or anything like that. And this again was the left eye, fairly flattened out cornea, pentacam looks fairly okay. This was the eye trace. So you can see here that the total abrasions are on the higher side. It's 0.185. So highly aberrated cornea, especially in the left eye, which was 0.474. So left eye, the cornea is highly aberrated, and we know that the interface is quite rough. At this stage, we know that the interface is obviously quite rough. On the ASOCT, again, you don't make out anything. There's no obviously retained lenticule or anything like that. So everything looks fairly normal except the abrometry tells us that it's a highly aberrated cornea and the interface may probably be a little bit rough. So what do you suspect? How do you proceed? Now this is the kind of case in which the diagnostic tools become really important. Not only do we have a topographer, but we have an abrometer, we have the MS39 and we also have the HD analyzer. Now it's not compulsory to have the HD analyzer in your practice, but for these cases which are less than 0.5% of cases, it can be very valuable in telling you what is wrong or what the patient is actually experiencing. So we did the HD analyzer for this patient. You can see the right eye, the OSI is 4, which is quite bad, and the left eye OSI is 8.8. So you can see the simulated images. In the right eye, the vision is quite blurry, but the left eye patient cannot see anything, right? So clearly a very aberrated cornea with poor vision, poor quality of vision. So now you take the retroilluminated slit lamp photographs and this is what we see. Look at this. The interface is so rough, right? The pupil is dilated and you're retroilluminating it. On the left side you can see the circular pattern. This is how the energy is delivered onto the cornea. But on the right side you see near the Purkinje image there is almost like a dent. It's depression sort of thing there. So which is why the left eye vision is so much worse. So it was a mystery. Why is the interface looking like this? Why are we seeing this kind of circular pattern, right? So it was like the crop circles that you see in farming. So Dr. Ganesh called it the mystery of the crop circles, right? So then what was done was a little bit of investigation. Went back to the preoperative energy settings. So can you see this? The energy is so high. You see the energy offset is almost 40, which is extremely high. Energy index of 40 is extremely high. So the surgeon wasn't really sure what energy settings to keep. So by mistake, he has kept a very high kind of energy setting. You see the energy index here, it's 40. So it's an extremely high energy. So although the surgery was completely uneventful, this tells us how important energy optimization is. There have been so many studies, and even our group has now done a study on the Visomax with 1500 eyes where we've used very low energy, almost 100 or 110 nanojoules. So earlier it was thought that anything up to 200 nanojoules is okay, but David Donate and group started experimenting with low energy settings of about 100 nanojoules, and they found much better results on post-op day 1. So once we optimized our energy also, we brought it down to about 110 nanojoules. That's an energy index of about 24 to 25, and sometimes even 22. The thing is, each machine is different, so you need to optimize the energy as per your machine, but still the energy offset of 40 is extremely high. Anything between 100 and 150 is acceptable. So now we know what the problem is. The surgeon used a very high energy and ended up with a very rough interface, and that's what's causing the highly aberrated cornea with poor quality of vision. So what can you do now? What are your management options? So the second treatment was planned and the Circle software was used with a PTK to smoothen out the interface. All you can do is now try and smooth out the rough interface. So this was the second surgery. This is what it looked like. You see the Circle software. It extends the cap from the edges to the periphery and it creates a side cut to create the flap. That's the side cut. And again, it's a nasal hinge because superiorly you have the smile incision. With the Circle software, you should generally keep the nasal hinge. So this is how the dissection is done with the Circle software. Again, this instrument is the usual Siebel's flap lifter, which is used to open up the edges of the flap, and it's opened all the way around, and the sharp end of the flap lifter is used to neatly open the flap. So you convert the cap into a flap. Can you see how rough that interface is? You see the granularity and the roughness in the interface. So now the laser is used to smoothen out that interface first. It's a simple procedure, it's a 20 micron PTK that's done. It's just smoothening procedure. So we're not changing the refraction here. We just want to smoothen out the interface and see what the refraction is at the end of it. We're not doing any treatment for sphere or cylinder at this point. The flap is carefully reposited back and the PCL is applied. So the procedure for the circle software is fairly simple. You just need to know the settings. The docking is also the same, laser delivery is the same as your femto flap. You just need to know the settings. Even the surgical steps are quite similar, only difference is that the hinge is nasal rather than superior. So this was the end of that procedure. Now, you can see after the PTK what the interface looks like. It's better. So the uncorrected vision in the right eye was still 612 and the uncorrected vision in the left eye was 624. Now the good news is the right eye with correction was improving to 6/6. So that's great news at this point for the right eye. The left eye was still improving only to about 618 parts because you can see the interface is still a little rough and the residual refraction in the left eye is more than the right eye. So then after 15 days, what was planned was another topography guided LASIK enhancement for both eyes to try to correct the residual refractive error. So the same flap was lifted and a topography guided treatment was done for this patient. And then look at the interface. So after the topo guided treatment, it was even better. The right eye was improving to 6.6 with just a -0.5 cylinder, and the left eye was improving to 612 plus. So it was almost like 6.9 parts with a -1 diopter cylinder. So at this point, this was just 3 months. This was 3 months post the LASIK enhancement. So 3 months after the last procedure that this eye underwent. And this was what the OSI looked like 3 months later. On the right eye, it came down to 0.7 and the left eye was still 2.8. So even after the PTK smoothening, even after the LASIK enhancement, the interface still was quite rough. So this is the importance of energy optimization. Once you use a very high energy, it's very difficult to treat and smoothen out these corneas that are very rough and very aberrated. You can fix it to some extent. The right eye, luckily, we were able to completely fix it. It was 6.6 parts. But the left eye, again, 6.9 parts, which was, of course, much better than 6.24 when the patient came to us. But it's not so much because of the refractive error, it's more about the interface and the roughness of the interface and the OSI, which is causing a lot of scatter. So that's why the quality of vision is very difficult to treat. This patient was relatively happy after the treatment, after we fixed what was wrong with the eye, but at the end of the day, energy optimization is one of the most crucial factors for visual recovery and quality of vision, especially day one vision. Aberrometry and topography sometimes may not be very useful for interface assessment, so you have to dilate the eye and take a retroilluminated slit lamp photograph. The OSI on the HD analyzer is quite a sensitive parameter to measure the interface quality and scatter, and these are some unique ways of management of interface roughness using circle software and PTK. Thank you very much for your patient listening. I hope that was helpful.
Thank you for a very interesting case. Any comment or questions? Okay. Thank you for attending for our session. Time's up, so let's finish our whole session.
Thank you, Chair and our speakers and all the attendees. So after this, we have an optional Wetlab demo. We're very honored to have Dr. Supriya as our instructor. So if you are interested to try the Wetlab, it's at the level 2. We can go to the Wetlab now. Yes. But it's optional, yes. Just come to me if you would like to do the web lab. All right, thank you. Thank you, Dr. Yu.